have these regularly and come and join us, and there's lunch. So today, we have Fengli Xu. He's a fellow with us, a postdoctoral fellow that came from Tsinghua University on the joint fellowship with there, and also with the Knowledge Lab and James Evans. And so Fengli does a lot of work about cities, but really driven by new, bigger data, often from cell phones. He's done work with Street View and other large data sets that allow us to characterize urban environments and behavior from, for example, people's mobility choices or some of the visual features of environments we live in and so on. And so I think he's done recently a lot of work analyzing patterns of mobility change segmented by various socioeconomic characteristics using cell phone data. And he's going to tell us about it in the context, I think, of COVID-19 and some of its implications for I think vaccine distribution, which I haven't seen yet. So Fengli, welcome again, and for sharing your work. And as always, this is quite informal. I think we can invite questions as we go, but I'll try to keep time and get us to the end more or less at time. So Fengli, thank you.
I think my topic is about social vaccine distribution. So I was wearing the mask. Maybe I want to give you a vibe of what we have gone through. So, but I really hope this is like a retrospective study. So, so the topic is strategic COVID-19 vaccine distribution can simultaneously elevate social utility and equity. So what do I mean? So the COVID-19 pandemic has exposed and intensified the disparities in the health risk faced by different urban communities. Right? So there's some previous work defined that, well, the neighborhood with lower socioeconomic status face a higher COVID-19 related deaths. And of course, we all know that the older people, the people with existing health conditions are also more vulnerable to the COVID-19 virus. So the vaccine has been a very critical resources we have to combat this virus. But inequitable vaccine distribution strategies may further exacerbate the existing health inequities. So this picture is the frontline health workers in Stanford medicine, I think, protesting the vaccine prioritizing algorithm that only give 7 doses out of the 5,000, the first 5,000 batch to the frontline health workers. But the others are all given to the staff and the faculty that work from home. So yeah, so there have been some popular objective in the medical resource allocation, especially during this COVID-19 pandemic. So the first is we call it the so-called year of life loss, the YLL. So if you assign, generally you want to minimize the overall year of life loss. So because the young people, they have a higher chance to get through this virus, to combat this virus, and they will have longer life expectancy, right? So this year of life loss objective will generally assign a very high weight to the young population. So if you can remember, when the pandemic is first just begin, the ventilator machine is so precious, it's so little, so scarce, right? So many countries, they prioritize the ventilator machine to the young people, to the young patients, because they think they actually have higher chance to make through. And saving them are saving more years of life. Okay, but this might have some utilitarian grounds, but it's also very controversial in moral standing. So, and the WHO rejected it in the resource allocation, and there's also another utilitarian objective. That's the number of life loss. So we want to minimize the overall life loss. So there's like a total utility, not the marginal utility of the year of life. So, but this will still like assign a relatively higher weight to the young people because they have higher chance to get through maybe. So on the other hand, there's another objective is like they call it the equal opportunity to live. So in this objective, you will naturally assign higher weights to actually the disadvantaged people, maybe the old people, the household with lower socioeconomic status, as previously discussed. So you want to minimize the difference in mortality rates across some demographic profiles. So it seems like, well, the number of life lost, like that's what we call maximizing the social utility, are at odds with the maximizing social equity. Right? So because one is like we want to prioritize maybe the young people, one is like you want to prioritize the disadvantaged people, maybe the old population. So this actually, these are two of our objectives here actually echo the principles of this national academics here for their proposal for equitable vaccine allocation. The principle of maximum benefit, you want to minimize the deaths of the whole society, and also the mitigation of health inequities across the communities. So, well, if we want to model a contagious disease like COVID, then first we need to have an epidemiological model. So there have been some choices, some standard models. The most classic one is the standard SER model. So the standard SER model, it basically assumes that it has a very strong homogeneous assumption underlying this model. It assumes the population has basically a homogeneous demographic profile, and they will have homogeneous population mixing. So each one in the city have similar probability meeting each other. So they will spread the disease homogeneously. So, but that obviously is not the truth, not right. So, for example, my footprint is largely confined in Hyde Park, right? And maybe a delivery service people will go all over the city, and maybe old citizens will generally are more vulnerable to the virus. So the population, the urban population, are not homogeneous. So that is a very big assumption to make. And another model is the meta-population model. So in this model, they generally break the population into several subpopulations, and then they consider the interaction between the subpopulations. That maybe it can be a heterogeneous interaction among the subpopulations, but they also overlook the difference of the demographic composition. So to do our study, so we first collect some data. So we want to use data to revisit the strong assumption of those previous models. So we first collect one large scale mobility data from the SafeGraph website that's open source, and we also collect the demographic profile of the census block from the American Community Survey. And then we also collect the daily deaths associated with COVID-19 infection from the New York Times. And we simulate the epidemic process for 9 MSAs in America and for 60 states. So we want to, what we want to do is we want to simultaneously capture the two heterogeneous factors we think that are very important in the urban environments. One is the mobility behavior. So we want to know how, we don't want to simply assume people have some homogeneous interaction, right? So we want to know maybe how people really move in the cities, how they really spread the virus, and also the demographic profiles, and especially the age, because there are very strong correlation with the infection fatality risk, the IFR. So what we do is we propose, we call behavior and the demographic model here. So in the model, we first break the urban population into several subpopulations based on the CBG, the census block groups. Okay, and we modeled their interaction, the interaction between census block group based on the mobility data that we extract. Specifically, we extract a bipartite graph between the CBG, the census block, and the POI. So the POI is some venue that have a specific function, maybe like a restaurant, like a school, like a park, or this kind of venues. So we model the mobility as a bipartite graph, and the graph is extracted from the real world mobility data. And for each census block, we run a separate SCR model with the IFR, the infection fatality rates are modulated by the demographic profile. That's the age, the average age of that demographic of that census. So
Can I ask a couple?
Yeah, please.
Technical questions. So first, give us a better sense of the POIs. Do you think you have all the POIs in the city, all the places that people can go to are public, shops and so on, or is a subset, or how do we think about it? That's a good question. And the other question is, you don't have data to run the SCIR in each census block, right? So you have to infer. So part of what is important is how many cases might you have and where, what's the contagion, right? So you only have county level data.
Yes.
So how, and these models are very sensitive because they're exponentially sensitive. They can be open. So how do you handle that under specification?
First about the POI. So I think the data set we have, it has a very good coverage of the point of interest. So it has about 400 plus thousands point of interest in this MSAs. I'm not sure about do they cover exactly every one of them, but I think that's a.
Like they have every restaurant, every grocery store, is that right?
Yeah, I think probably. Well, you have a good coverage because the quantity is smart, and it covered the mobility trace of all the citizens, all the residents of the CBGs. So I think it should be a very good coverage.
I think it's worth checking because we've used the data as well. And the commercial coverage is quite okay, but other places like nonprofits, hospitals, or whatever, I mean, bigger hospitals like needed, but smaller health clinics.
Chris, what's the temporality of the mobility data? And I think I saw that it might be taken during the pandemic, but I wasn't.
It was during the pandemic. It's the I think it's the first 60 days. 60 days when the vaccine are first available.
Mobility data.
Yes. Yes.
Okay. I'm just wondering, how does that benchmark? So that benchmarks in kind of quote unquote return to normal or something like that.
Yeah.
So just like the first 60 days that the vaccine is available, so things are largely in lockdown in the United States. So that'll massively understate people's common mobility.
Yes. Well, that is a very interesting problem. So how the mobility change with the pandemic. There's the interactive. So the pandemic will impact on the mobility, and the mobility will also impact on the pandemic. In return. So we'll cover that a little bit later. But I think that will be a very interesting topic.
I'll keep looking. That's an interesting benchmark that.
Yes. And the second question of Luis is how we fit the SCR model in the center. So I think the good thing of SCR model is largely simplified a lot of underlying process. So we only have a small amount of parameters of the process. So we are fitting all of the models on the MSA level. So we only have one curve of the MSA. So we assume the SCR between them are sharing a lot of parameters, like the average spread rate. So the only thing different between them is the IFR, is the infection to fatality rate. That is based on the demographic profile, like whether your center block has a lot of senior citizens. And this IFR model, these IFR parameters, we used one recent medical research. So there's a click data. So we didn't fit the IFR ourselves. So yeah, so that's how we fit it. Yeah. Okay, so let's go to the briefly go to the results. So the first thing we can see is our model can actually better track the curve of the daily fertility. There are two examples of San Francisco and Dallas here. So if we only use the gray curve here is the standard SER model, and the green curve is the ground truth. The blue curve is the meta population. We can see that the orange curve is our model. We can see that our model can track the real world, the ground truth much better than previous existing models. And quantitatively, while the normalized RMSE, well, the root mean square errors are reduced by about 80% in our models. So secondly, we can also see that our model can allow us to better to analyze the inequality in urban space. So for example, if we are using a SER model, that is the gray line here, because the SER model assumes homogeneous population composition and the homogeneous population mixing of all the CPGs. So you will have similar mortality rates for all the center block, right? So you have a flat curve here. So the curve in these figures, we first disaggregate the center block, and we first rank and bin them into 10 groups based on the age, the average age. The last figure here is based on age, and the middle figure here is based on the average household income, and the essential worker ratio and the minority ratio, the racial minority ratio. And so the first group here means the 10% census block with the youngest population. And the 10th group here means the 10% census block with oldest population. And also about the income, the essential worker on the right figures. Okay. So we can see, well, the gray line here, it predicts, well, they will all have a similar mortality rate, right? And the blue line here actually predicts the young people will have a higher mortality rate, because the blue line, the blue models, they do not consider the demographic composition. You only consider the heterogeneous mobility behavior. So the young people have higher mobility level, and they assume they are more vulnerable because they move around in the cities. Okay, so but if we consider both the demographic and the mobility behavior, we can maybe we can correctly recover that. The old population face much higher vulnerability risk, face much more higher risk, and also we can also predict the lower household income. Neighborhoods also have higher risk. The essential worker also correlated with the essential worker ratio, and the minority ratio also correlated with the COVID-19 fertility risk. So the reason is largely because of the demographic specific fertility risk and the mobility behavior. So we can see that, for example, like the household income here has a significant negative correlation with the per capita mobility. So it means, well, the census block with generally lower income will have higher mobility level during the pandemic. So here I want to come back to Chris' question about how the mobility behavior changed. So we have an analysis that the household income actually have a significant positive correlation with the income before the pandemic. So if we look at like the first 2 months in 2020, so that's before the pandemic in United States, then we can see that the high income census block have a much higher mobility frequency and mobility diameters. But after the pandemic come in, so the pattern reversed. So it means the high household income families they can afford to more mobility reduction during the pandemic. Maybe they can stay at home for work, and that is how the mobility change have an impact on our study. And well, I think they could resume to some level of normal now. But that is like a separate project we are working on now. So.
Do you have a sense why the error bars are so high for income the work-rate minorities? For your model, right? So
in the upper
yeah.
figures, why the bar are so high? So okay, I think that's a difficult question. I think it could be because there are, like Louis said, that there is exponential difference in the transformation. So they have some. So the error bar here basically capture the uncertainty in the simulation. But sometimes, well, a small variant can be amplified during the pandemic simulation because it's exponential process. Right, 1 people will spread to 2 people, and 2 people to 4 people. So I think that could be the reason why it is higher.
Did you look at what the representation of, for instance, low-income population is in the mobility data and SafeDraft? It's one of the things that Jamie Saxon found when you look at similar data is that there really is a bias towards higher income people in the mobility data because they tend to use the devices more, etc. And so that, I mean, part of the question is if the uncertainty in these areas is also driven by the fact that we have less data.
That's a very good question. So there have been, well, it definitely have, well, it definitely has the sampling bias problem, well, in the empirical data study. So, but the SafeDraft data set, they also provide augment method. So you can correct the bias to some level, to some extent. So they provide a method to do that. So we actually follow the process of one previous published paper in about how to adjust the sampling bias problem.
This is more about pandemic or nursing homes, and so presumably, that the oldest population is not only do not have mobile devices, but they also are not very generally. So, do you think this study is undercounting those types of people?
Well, I think that's a very good question. We do consider that. So, in a nursing house, so they are likely to be in the center block. So it will have a more deadly transmission within the center block. So because we are running a different SER model for each center block. So I think we can account for that to some extent, but definitely maybe we need a more fine-grain to a urban value level simulation, not a city-wide simulation to consider specific kind of interest.
Just real quick, if you use the SafeDraft adjustment, they often use the very variables that you're also using then in your average household income. Right? So that the other question is how far you're picking up something that you put in through the SafeDraft adjustment.
I think what we use we don't use the demographic adjustment maybe. So it's like more like a center block level and the point of interest of adjustment, and also the city. Some city have a higher sampling rate. Some cities have lower sampling rate. So,
can we just a clarifying question? What are the dots in these lower panels?
Oh, the dots is the center block. The center block. So in the lower panels, right? Okay. That's center block, right?
I expect you to have. So this is for a particular city?
Yes. This is from one example city.
Okay. I thought you'd have more.
Yes, we run it on nine cities, but many of the figures are in the supplemental
for a particular city. Yeah. Okay. How many census blocks do you have in Chicago? I thought you'd have more.
2,000.
Got that 2,000 points there.
This is a heat map, so some of them are aggregated to the color. Yeah. Okay. So the big question is how we can achieve a desirable trade-off between the social utility and the equity. So people will assume we have to trade off, right? So maybe we have to trade off between them. So, but actually, while we test two very simple strategies. One is we just prioritize the most disadvantaged group based on some demographic dimension. Like the upper left figure is based on age. Like we just prioritize the oldest center block. Yeah. Okay. So the upper right is prioritized by income and occupation and by race ethnicity. So the origin of these four plots here are the performance of randomly distributing the vaccine. So we just randomly distributing like 10% of vaccine on the whole city population. So it is the origin point in these four figures. It's like the benchmark here. So the red dots here is prioritizing the most disadvantaged center block. Right? We give all the 10% of the vaccine to the oldest, or the poorest, or the most has most concentrated essential workers center block. So the performance is the red dots here. So surprisingly, we can find that the red dots are mainly concentrated in the first quadrant, right? The upper right quadrant. It means we definitely can see an improvement in equity because we are prioritizing this disadvantage group, right? We can also see an improvement in social utility. It means when we are minimizing the equity, minimizing the inequity of age group or of income group, we are actually also minimizing the overall fatality rates in the whole city. So we can, the social utility and the equity can be simultaneously improved if the vaccine access is prioritized for the most disadvantaged communities. So here the social utility is measured as the number of prevented deaths, and the equity is measured as the Gini index of the mortality rates of the subpopulation group based on the defined on age, income, or occupation. Sorry. So yeah, and some might argue that our setting might be too ideal. But one reason is the vaccine hesitancy. So actually, some reviewer raised this question, like, some of the disadvantaged group, marginalized demographic group, they also have higher level of vaccine hesitancy. So when you are prioritizing vaccines for them, maybe you also have a higher cost to administer the vaccine. So here we used one national survey about the vaccine hesitancy profile. So we can see that the household income do have a negative correlation with the vaccine acceptance. So the low income household somehow has a relatively lower vaccine acceptance. So if we also can consider the three scenarios. Like we assume the lower income groups have a much lower, about 0.6. The lowest has 0.6% acceptance rates compared to the highest income group. And in the hypothetical scenario 3, that it has only 10% of the acceptance rates compared to the highest income group. So, but in this hypothetical scenario, you can see that the social utility change are still positive. So I mean, even if when the prioritizing the disadvantaged population group are more costly or maybe less efficient because the potentially the possibility of vaccine hesitancy, the higher possibility of vaccine hesitancy, it can still improve the social utility. As long as before the scenario 2. So that's as long as the poorest subpopulation and the acceptance rate of the poorest 10% of the income groups are higher than the 20% of the highest income group. So it means the social utility, the finding that we can simultaneously improve the social utility and the equity are robust, even when we can consider the vaccine hesitancy of these marginalized subpopulations. So that's very good news, right? But the problem is, if we look into the different demographic, so we can see that the equity defined on different demographic features, they are often at odds with each other. So for example, if we want to prioritize by age, we want to prioritize the census block by age, then we will often see a reduced equity in occupation, or reduced equity maybe in race, minority, in income group, in some other dimension. So it means, although we can achieve simultaneous improvement in social utility and equity, defined on some single dimension of demographic, with simple vaccine prioritizing strategy, but the equity defined on different demographic profile, different demographic feature, are at odds with each other. So when we are prioritizing old people, then maybe we are leaving out the the lower income household. So the reason for that is because of the correlation between different demographic profiles. So for example, in the leftmost figures, we can see that the household income has a positive correlation with the older adults ratio. So it means, in the center block with more old population, you generally have high income. So if you are prioritizing them, then maybe you're leaving out the lowest income groups. So yeah, these four figures here shows there is complex correlation between them. So maybe we shouldn't design the vaccine policy based on one simple dimension of the demographic. So in order to have a more comprehensive vaccine distribution strategy, here we propose two indexes. One we call the community risk. So it means how vulnerable is this single community, is this community block itself. So it is computed as the expected number of deaths caused by infection in a community. Okay. So it means, if vaccinated, how many number of lives you can save in this community. So it is a concept related more with the equity. Okay, and the second index is the societal risk. It means the expected number of deaths caused by the infection in this community and the induced secondary infection in other communities. So like how many deaths it will create in other communities the transmission. Okay, so the rationale is to, if vaccinated, how many number of lives you can save in the whole population in the city. So that's more related to the social utility objective one. So here we can see that our two index is very informative to predict, to estimate the two objective one, the social utility and the equity. So here we compare the black box here is the regression model run on only the demographic feature, and the red box here is the regression model when we add in the two index we have, the two index we just proposed. So we can see that the regression model can explain much more variance after we add in those two index, and it is true in predicting the social utility in the left figure and predicting the equity defined on 4 demographic dimensions in the right figures. So it shows that our proposed index is very informative. So, and this can also allow us to explore why we can achieve a simultaneous improvement in social utility and equity. So because there's a small typo, because the societal risk and the community risk have a significant positive correlation between them. It means, the most vulnerable subpopulation are often the most dangerous subpopulation that will spread the virus to the whole city. They create the most deaths at the whole city level. So by prioritizing them, so we can achieve the simultaneous improvement in both equity and utility. That's the reason because behind our previous findings. So informed by these two indexes, the index of community risk and the index of societal risk, so we can actually design a more comprehensive strategy, we call it, that can achieve consistent improvement in almost every aspect, of the utility and the equity defined on different dimensions, all four dimensions of demographics. So in the left figure here, the red curve, the red line here is our model, and the green line here is what we achieve by only prioritizing the lowest income group. So we can see that the green curve can do a better job in reducing the inequity in income level. Right? It has a higher value, but it will significantly underperform our comprehensive model in other dimensions. So, and our model, the red line here, will achieve almost the best performance in all dimensions here. And then we also look at this SVI informed strategy. So the SVI index is the social vulnerabilities index. So it actually has been used by some local health authority to prioritize for the center block for vaccine. That is computed by some demographic variables by the CDC. So that's what people are using now. So we also try to test the robustness of our finding. So we test different scenarios, or like a different level of vaccination rates, and the different timing of the different timing of us adopting this vaccine sharing strategy, like in the first day or in maybe like a lot of days afterwards. So we can see the red line remain the best results we can achieve in all the settings, although the performance might decrease in some suboptimal settings. Okay, so here is the brief conclusion here. So the key message here, I think, is that we should generally consider the heterogeneous mobility behavior and the demographic profile in estimating the inequality of COVID-19 risk. And the social utility and equity can actually be simultaneously improved when we prioritize in the disadvantaged group for vaccines access. So I think the key reason here is because this contagious disease is not static. People will go around the city and spread it in a very complex way. So in this case, while many those vulnerable subpopulations, the most vulnerable subpopulation are likely also the most dangerous subpopulation that will spread the virus to the whole city. And finally, the empirical mobility data and demographic data can influence to design some more comprehensive vaccine sharing strategies. So that's all of the presentation. Thank you.
All right, questions? Please.
And what is the implementation of such a model?
Sorry?
How would you implement this model? What is the next step?
How do I implement? You mean how do I?
In terms of policy.
Okay, so I want to mention also this analysis is based on center block level. So it's not on individual level. So I think that's a more implementable at center block level. So you are just prioritizing the whole center block for vaccine access, maybe. And we only need the aggregates and anonymized mobility data of the whole center block. It's not a mobility trace of any individual. So I think that's a less privacy risk and more actionable. So you are just like in Chicago, you are prioritizing some neighborhoods for vaccine first. And I think because we can achieve the social utility and the equity simultaneously, and I think it's maybe less controversial. So because when we are prioritizing the most vulnerable groups, so it is also in the whole population's best interest. So like we are prioritizing the delivery service people. So like they will travel around the city. So they are more dangerous than they're more vulnerable than themselves, and they're also safer to the whole city population. So yeah, that's how we can implement it. Please.
I'm thinking about this research in like kind of scope of like other, the broader like policies and optimization, social optimization. So like, do you have the data granularity that asks questions like, let's say we really want to prioritize reopening schools even in this pandemic, and you like think of them? I'm kind of asking about data aggregation. If that's also a priority, then you're basically assuming pre-pandemic mobility at the K-12 schools or something, and then can develop vaccine strategies based on also having that mobility.
I think that's a very good question. So if I understand you correctly, so I think it's been like we have some maybe very specific goal. So we want to achieve through the like a vaccine distribution, like maybe we want to reopen school, and we can assume there's some mobility change after the reopen, so we can just optimize based on that.
Yeah, kind of optimize across the criteria, right? Like both social or equity and utility measures, as well as also trying to include something like K-12 education in that utility or equity calculus.
Oh, yeah, I think that's a very good question. So I think that needs a lot of assumption, like how people will behave. So after some policy is enforced. So I think a good way to do that maybe is based on a simulator. So there have been some work about like simulating the people moving around the city. Like here is a supermarket, here is a school, here is a what, and you have some parameter like people going into different places. So you build a simulator, and then you try to simulate how maybe you can change the parameter a little bit, like we open the school. Yeah.
This first part is the pre-pandemic mobility at schools is not going to be representative.
Yes, you're right. So yeah, so I think that's why it's like we need to have like some kind of counterfactual scenario. Like we kind of need to we can draw some patterns from the data, but we also need to assume some difference might happen based on maybe based on behavior study or things.
For example, contemporary mobility in schools, in terms of like, is there going to be another that is?
Yes, that's also possible.
Very cool.
Please.
Two questions. The first, so I know SafeGraph also has just census block group to census block group data, right? And that can capture more of like the neighborhood social trends that aren't necessarily to a point of interest. And so I was wondering if you looked at that as well, particularly as kind of the pandemic went on, that behavior of like parties and having dinners might be a vector that's really important. And the second question was, some of the most glaring inequities are within kind of working age groups. So particularly there's a study at UCLA that's like kind of the 45 to 55 group of working age people instead of for an overall population that can be a 1.5, 2x disparity in mortality, but in some of those cases in California, there's a 20x between Hispanic or Latinx populations and other populations. And so I was wondering if you had looked at all, thought about it all, isolating just a working age population, say 18 to 65, that might have similar mobility habits. Great work, thanks so much.
First question about the data. So you mean the sensor blocks for sensor block interaction? So definitely. So I want to mention, so like Julia previously said, well, there's a lot of questions maybe issues related to how to process the data, how to maybe refine it. So we actually follow the process in one of the previous published papers in Nature 2020. So I think that it will reduce our risk of how to handle the data. So that's why we use the sensor block to POI the network, and we adopt some process to reduce some bias in the data. So I agree, yeah, the center block to center block interaction that definitely is very vulnerable, very valuable in evaluating especially now, I think there's the social activity are back to normal. So yeah, I definitely look into that in our next project. So we are now looking at how maybe the mobility will return to normal in the post-pandemic era. Yeah. And the second question is, sorry, can you remind me?
But did you look at just working age population? Because that maybe gets rid of some of the uncertainty of older populations, and then I suppose very young populations with very different mobility patterns.
So the thing is, okay. So if I understand you correctly, so maybe you mean the old but not retired population are actually maybe more vulnerable than the retired population.
Yeah, or the disparities can be higher.
Yes.
You can observe
So that I think that's exactly why we see there's a trade-off between the equity in different dimensions. The solution we find is not look at the demographic actually. We don't look at demographic, we look at the behavior and demographic. We just look at how them travel, right? So if the center block they are old and they go out a lot, so it means they are vulnerable. So yeah, so that's what we call the behavior and demographic model. So thank you.
Thanks so much.
Question. I didn't understand the second part of your talk when you're trying to create these multidimensional criteria. Are you using the actual observed patterns of travel behavior during the pandemic?
Yes.
So the question I wanted to ask is, suppose you didn't know them because you're at the beginning of the pandemic, and you're trying to make a recommendation for how you should treat the population. Then you have pre-pandemic patterns that you've observed, and then you have to kind of think about what may happen. Would the recommendation be very different if you had pre-pandemic patterns of behavior?
We will. So like I said, before the pandemic, the high income group has higher mobility level.
So they'd be more vulnerable.
Well, yeah, that would be completely different. So I guess we need to assume, maybe like Chris said, we need to assume what will happen after the pandemic. So this pandemic maybe provide us with experience to that. So yeah. So
in some sense, I think it would be interesting to think, one scenario is that what you want to do is to distribute vaccination so that the pre-pandemic patterns of behavior could be preserved, so that people don't have to change their patterns of behavior.
yes.
And then I wonder if you have different trade-offs, right?
Yes.
Anyway.
That's a very complex process. I would say that the mobility behavior and the pandemic process,
Yes.
they are interacting with each other.
Yes,
Both direction, I think. Right.
Some kind of like at the census block level measure of usefulness of mobility or utility derived from this mobility. I don't know exactly what I think there would be a census block level or a census pairwise level of how important was that commute or something for whatever kind of outcome you have. Right, it has some kind of like a societal cost or something that we're trying to undo by vaccination.
So I think we have some of that consideration in our current policy because like we are prioritizing for those essential workers. So we have a definition for essential workers, right? I mean, maybe the first line health workers. So we have we have considered that in our current policy, but it's difficult to determine which travel is essential or not, only by the mobility data, I think. Maybe we can infer that to some level based on the destination, but people can go to the same destination for different reasons.
We could brainstorm.
Yeah, we can brainstorm there.
Right, any more questions? No one? Let's thank Fengli again. Thank you. Right,